of a transcatheter mitral valve replacement with a laceration of anterior mitral leaflet to prevent outflow obstruction, so-called LAMPOON procedure. I have nothing to disclose. So 74-year-old female presents with a severe mitral valve regurgitation after mitral valve ring reconstruction 2010. She presents 2014 with this high-grade MR with a HFrEF and multiple comorbidities. She was, of course, presented in heart team where she deemed prohibitive risk factors for surgery. So we proceeded with a transfemoral approach planning. So we decided to implant an Edwards in a mitral position. And whenever you try to do this or think of doing this, there's always that fear of LVOT obstruction. And this is the topic I'm focusing on today. This was a sufficient area from mitral valve area for a 26 Edwards Sapien, and with a 60-40 or 70-30 projection into the ventricle, we had a sufficient new LVT area. There is some data that says 190 to 200, you have to intervene, do something. The next picture just verifies what we measured. But from simple transesophageal echocardiography, you can appreciate that the AML is 28 millimeter and the LVOT is around 18 millimeter, which is a high risk for obstruction. And there is also data that says 25 millimeter AML, you have to do something about it. So we decided for LAMPOON. Alternatives were septal ablation. You wait 4 weeks, you ablate, you wait 4 weeks, and then you reevaluate, but the septum in this case was not hypertrophied. Surgery was deferred, and we remained with the LAMPOON procedure. LAMPOON is a procedure that can be performed retrograde or antegrade. The classical LAMPOON was retrograde, was first introduced here as shown on the left-hand side. Retrograde LAMPOON, where you go through aorta with 2 catheters, but it's technically challenging and might tether the mitral valve, causing a pulmonary edema. And the time from traversal to mitral valve replacement is significantly higher than the antegrade LAMPOON, which is the modified LAMPOON or the newly adopted LAMPOON, and now the standard way to do it. Is technically straightforward, allows for a stable catheter position to target the A2 scallop, which is our target to lacerate, and the time from traversal to valve replacement, to introduction of the valve, is significantly faster. I'm going through the steps step by step. So basically, introduce 2 catheters through a single transseptal puncture. One catheter aims towards the base of the AML, as shown here, and one catheter would go to the ventricle, and through the base would through a coated wire, penetration will occur, and the snare, a snare will be receiving that wire from the left ventricle side. The 2 catheters will be pulled together, and then another energy dose to lacerate the AML, to have like a V-shaped AML, and to in defect have a free flow through the TAVI stent. So this is the first step, where you see the 2 catheters in the left atrium, and one is already in the left ventricle. In the next step, there is a snare in the left ventricle waiting for the penetration from the left atrium. You can appreciate here the wire going through the anterior mitral leaflet, and here it's already gone through, confirmed by echo. You try to do it as central, as posterior as possible. Then, as shown on the right-hand side, this wire will be snared, externalized, 2 catheters will be pulled together, and this was already the laceration here. We applied like 50 watts of energy dose, and that's it. It happens in a second. Next step is just well, this is a free MR, obviously, after laceration of the AML, and here it's also confirmed that we had an adequate laceration. It can also fail, obviously. Next step is to go up with the valve. Important to take your time. important to have the projection which you planned from CT, around 70-30 in this case. And here, no turbulence in the LVOT. We see free flow and color Doppler, no MR whatsoever. And here, the AML was lacerated as confirmed here. And the pressure wave Doppler showed an excellent result with no obstruction whatsoever. And that's all what I have to say about this case. Thank you.